Ladies and gentlemen, good evening. Thank you for joining us. Welcome to yet another TEOXANE Academy digital event. I'm very, very pleased to kick off this digital engagement from Sydney. It's truly an international event. For those of us that I have not had the good fortune to meet in person or virtually so far, my name is Krish Sai. I'm the Regional Vice President for TEOXANE Asia Pacific and also General Manager for Australia and New Zealand. I'm right now in Sydney doing face-to-face events with Dr. Lee Walker, who you're very familiar, who's also a very close associate of Dr. Rahul Chetto. So we'll talk about that in a minute. So it's my pleasure to introduce Dr. Rahul Chetto for this event tonight. So the focus is going to be on lower face beautification. And we're very, very fortunate to have Dr. Rahul Chetto with his experience to talk us through the anatomy, the technique, and the assessment of aging, the injection strategy, and the product that he's going to choose, in short, from biology to rheology. The setup is going to be a 30 minutes of presentation of Dr. Rahul Chetto's perspectives of lower face beautification for both male and female. And then he's going to have two models to live inject. The first is going to be a Caucasian female, and then after, followed by a Caucasian male. Jacqueline Unga, Medical Education Manager, who's in Singapore, along with Melanie, in setting us up on this event, is going to interact with Dr. Rahul Chetto, or moderate rather, as he finishes his presentation. She'll take a few questions. If you can pop them in the chat bar or Q&A. And then as Dr. Rahul Chetto is injecting the first and the second cases. She's going to keep it alive and ask some questions. So please do nudge Jack if you have any questions that you want Dr. Alcheto to answer. Now, for those of you who have not had a chance to meet or interact virtually with Dr. Alcheto, he has a beautiful clinic in central London. I've seen it, and that's where he's beaming live to us. I'd love to go and see them once the Europe travels open up and we feel a bit comfortable to travel from Singapore. 16 years of medical practice. He's an ENT surgeon, about a decade of aesthetic practice. Clinic 1.6, that's an interesting name. I never asked him before why he got that name of 1.6. So maybe we should start with that, Raul. Very, very curious individual, passionate about medical education. Before that, I should recognize Dr. Cheto's PhD on nasal airflow. That shows his curiosity to demonstrate and validate hypothesis. And while we were all busy listening to him during the last couple of years of COVID lockdowns, he's managed to somehow find time to undertake a master's degree in medical education. So brilliant setup for us. That's what we want to hear and see more of. People are passionate about sharing their learns and wins with others so that collectively we can raise the standards, our own standards of clinical practice. And that's what we love to do at TEOXANE. If I could give a quick plug for our TEOXANE digital platform, COVID has forced us to do things in ways we did not imagine. And as I look back at 2021, it's astounding that we have had about 35,000 physicians attend our webinars more than once. We have 16,000 physicians registered on our TEOXANE Academy Digital, where you have free content available 24/7 on demand of webinars such as this or medical education modules. So if you're one of those who's not yet been on TEOXANE Academy Digital, please get online or send a note to our partners across Asia or across Asia Pacific or Europe, where you're from, and we'll be more than glad to help you. We all at TEOXANE believe education should be accessible, education should be free, education should be comprehensive, and it should raise the bar on what we do collectively. Products, if they're good, the results would speak for themselves. That's what we believe in. So, ladies and gentlemen, it's my pleasure to hand over to Dr. Raul Cheto now to talk us through his perspectives, followed by 2 live demonstrations. Dr. Raul Cheto, can you hear me?
Yeah, absolutely.
Fantastic.
Thank you so much for the wonderful introduction, Krish. And it's an absolute pleasure to welcome you all to my clinic here in London. I had the pleasure and the privilege actually to be in Singapore for around 10 days. Just came back over the weekend. And just like lots of you welcome me, really make me feel at home to your clinics and engage with us. I'm very, very happy that we can do this virtually here from my practice. So what we will do is we will start with a short presentation, as Krish pointed out, because then we want to focus on the practical component, which is something that we're really looking forward to sharing with you. The focus of this presentation will be to do the lower face, but the primary focus will be for us to concentrate on the differences between male and female. And that is something that is important because we see that as these treatments become more and more popular, we're seeing a lot of our female patients being masculinized and some practitioners are not really respecting gender, which is what we will focus on. And we will, next slide, please. We will do this and we will also make sure that we can know some of these 2 differences. So first, why? There has been a significant increase in the demand. And this is a survey from some of our colleagues from Italy, where they reported over 50% growth in the demand for lower face treatments. And you can all relate to that because as these treatments that we do become not just more popular, but there's less of a stigma attached to them, our patients request, and they know what we can achieve with dermal fillers. So for example, our male patients want us to enhance, their characteristic features, the wider chin, the more chisel look, the increase in the bigonial width. Our female patients really want a straight, uninterrupted mandibular line. They want softer contours as well in the chin, and they know that we can achieve this with dermal fillers. And this is why now we are actually doing these treatments not only for treating the aging process, but we are also doing these treatments in order to do beautification, to enhance these both male and female features. Our approach as a company to facial aesthetics is an evidence-based approach, and it focuses on the anatomy and the assessment of our patients. Based on this, we will meet our patients' requirements by adjusting our technique and what works best in our hands. But then the third thing that we always take into consideration is the rheology. We have seen incredible advances in rheology over the last decade, and RHA is one of these advances, as we'll touch on later on. And it's no longer sufficient to have the same diluted rigid product for all of these different layers of the face that we're treating. So we want really the rheology to accompany the natural dynamic aspect of the face. So we begin with the anatomy. If we peel the skin here, what we see first is we see these superficial fat pads. And if we focus on the lower face, we can see that we have the jowl fat, we have the superficial fat of the chin, and then we have that lower portion of the middle fat pad. And all of these are very relevant for us as injectors, because remember that they age and they also give that soft or sharp contour to the lower face. If we peel that second layer and we focus on layer 3, we see the musculature. What is important here with the musculature is that if you take the chin into consideration, we have a highly dynamic area there. We have those 18 muscles on each side that connect to the orbicularis oris muscle, but we also have that mentalis muscle, the elevator of the lower face. We have the DAO muscle, we have the depressor labii, we have also the orbicularis oris muscle. And if we go more lateral towards the jawline, we will have the platysma and we will also have the masseter. So we really are able to see and separate the lower face into a very dynamic and mobile anterior part, which is the chin, and a lateral part, which is the jawline and the gonial angle. If we focus on the more deeper layers here, and especially on the deep fat, remember the deep fat is static and it's attached to the bone. We have a deep fat compartment on the pogonium attached to the chin, to the bone. But we also have a second one that is not on this slide, which will be attached to the inferior border of the mandible. Now, why is fat important for us as injectors? Well, because the fat ages. And in particular, the superficial fat here in the lower face is of the utmost importance. Because here we can see in this dissection, we have the jowl fat, but we see these two fixed structures, the mandibular ligament and also the premasseteric ligament. These are true ossicutaneous ligaments. So that means that they don't age. And in between those two ossicutaneous ligaments, those two rigid structures, there is a hammock. And this hammock is the jowl fat. And the jowl fat, as we age, expands. So because it's in between these two palm trees, these two fixed structures, it has only one way to go, which is down. And that's why the jowl disrupts the mandibular line and creates that sagging. But also, if we look at the chin just medial to the mandibular ligament, we will also see some deeper changes as we age, but most importantly, we will see the superficial fat atrophy of the chin, leading to that dynamic discord, which will be that hyperactivity of the mentalis and the DAOs pulling the corners of the mouth that we see with the aging process. And this is why the ligaments are very important for us as injectors, not just for treating the aging process, but also for doing correction or beautification treatments for our younger patients. And this is why we identify them in our patients. And also we tend to mark them when we are doing our treatment so that we can separate the chin, the jawline, and the gonial angle, as we will see later on with our patients. Now, in terms of the anatomy, for us as injectors, we have to view the anatomy, the different arrangement of layers that we have. And if we focus on the lower face, the chin in particular, we have traditional arrangement of 5 layers. So we will have the bone, then that deep fat attached to the bone, then we will have the mentalis muscle, the superficial fat, and the skin. As we go more posterior to the mandibular ligament, we have a slightly different arrangement of layers because we have that complex arrangement of muscles where we would see the platysma muscle, the DAO, be in very close proximity to the mandibular ligament. And we would only see deep fat there on the inferior border of the mandible. But if we move more lateral in the lower face and we focus on the gonial angle, here we have a different arrangement of layers because we have bone and then muscle that is attached to the bone, in this case, the masseter muscle. Now, above that muscle, we have the parotid gland and its enveloping fascia. And then above it, we have the superficial fat and skin. So a different arrangement of layers as we have bone and then we have muscle attached to the bone, very similar to the upper temporal compartment. And also we have the parotid gland there in the way. So it's important that we familiarize ourselves with this different arrangement of layers because we have to think of how to maximize the expression of the volume we're injecting with filler. And we always have to question ourselves, am I going to be more efficient by injecting deep down on the bone or more superficial? And this is something that we practice with our patients and during our assessment. Now, if we move on to the vasculature, we have deep here in the mandibular notch, the facial artery and vein entering the face, and the facial artery will give off its labial artery, it will give off this submental artery that then becomes the ascending mental artery around 6 millimeters from the midline of the chin, ending in layer 3 in the muscle. And the facial vein, as you can see, runs a different course to the artery. To us, well, because we will adjust the depth of our injections based on the depth of these blood vessels so that we can be away from these vascular delicate structures. So to summarize really the anatomy, we have a different arrangement of layers between the chin, 5 layers, and the gonial angle. We have 6 layers, but different arrangements when we have muscle attached to the bone. And this is important for us in order to optimize our injection depth and maximize the efficiency of our volume. So this is something that we will practice with our patients and we will always have in consideration when we're planning treatments. Now let's move on to the assessment. And this is where we will focus on the differences between our male and our female counterparts. So what are the indications here for treatment? Well, for this younger cohort of patients, we're not necessarily treating the aging process. What we are doing is we are creating more efficient. We are also doing corrections. So things, for example, like treating a class 2 chin, these are things that were traditionally surgical treatments and now we can do with our injectable implants. We're also enhancing both the male features as well as the female features. So these is why there is a large cohort of patients that are seeking treatments at a younger age for the lower face, as we know that they're very high impact treatments in that younger generation of patients. So if we move on to the assessment here and we focus on the bizygomatic and then the bigonial width, you can see that here for our male patients, the bizygomatic width and the bigonial width are very similar, whereas with our female patients, and this is the same across all ethnicities, we will see that the bizygomatic width is the more dominant one of them all. Then this results in that natural oval facial shape that we tend to see with our female counterparts, where the bitemporal width is lesser than the width, and the bigonial width is lesser than the bizygomatic width. Now, this also plays a very important role when we discuss ethnicity. And this is something that we will get onto in a few seconds. From a lateral perspective here, and we look at different publications here for this, and we focus on the two that have the most robust methods. And we look at the gonial angle here from the male patient is around 100 degrees, whereas our female patients will have a more obtuse angle of around 130 degrees. But remember, from an anterior perspective, the male bigonial width is always greater than the female one. Now, if we focus on the chin from the anterior perspective, we can see that the male chin is broader as its width corresponds to the width of the mouth, whereas the female chin width, it corresponds to the intercanthal width. And if we take into consideration ethnicity, the two areas where we will see the most variation is going to be within the intercanthal width and also within the forehead. And that has, as we know, a direct impact on this lower third. So this does not mean that the female chin is rounder or it's smaller. It just means that its width will vary across ethnicity because it will correspond to this intercanthal width. From a lateral perspective, I know that this cirrus meridian plane is a radiological landmark. However, we use it also as a guide for us for projecting the chin. And you can see here the differences between a class 1, where that cirrus meridian plane is within a millimeter or two from that line. But then we see the differences there between a class 2, where the chin is behind that line, and a class 3, where the chin is more forward or more anteriorly projected to that line. And this is also something that we consider in our male patients, because with our female patients, you want the chin to be within 2 to 3 millimeters from that cirrus meridian line. But with our male patients, you can actually afford to project that chin even about 1 centimeter to 2 more anterior that line. It corresponds to the proportions of the male face. From an anterior perspective, again, it's very important that we take not just gender, but ethnicity into consideration. And we see that in the Far East, we will see that the requested treatments are different to what we see here in the West. So one of the things that we see is we see that the maxilla is wider, and also from a profile, it lacks some anterior projection. But also we see that wider intercanthal width because of the musculature, because of the projection of the musculature. And this is why one of the most, if not the most requested treatment in the lower face in Asia will be the reduction of that bulk of the masseter mass in order to give a more oval facial shape. So this is something that I would do before a hyaluronic acid dermal filler treatment, because I would want to decrease that bigonial width if that was the case. And also, how do we slim a face? By bringing it forward, by adding more volume and bringing it forward. But as you can see, in the Far East Asian patient, we will add the volume for the mid-face in a slightly different area than what we would in a Caucasian patient. So wider bitemporal, bizygomatic, and bigonial distances in our Asian patients, a more retruded and concave maxilla, puffier eyelids, and also epicanthal folds. And this is why, for us to achieve that oval facial shape, sometimes we have to decrease these widths, in particular, the bigonial width for our Asian patients. And also we have to pay very careful consideration when treating the mid-face, not to increase the bizygomatic width for our patients. So other things that we want to consider here is we want to really take into consideration the nose to chin relationship. So for this, you can use the Ricketts plane in order to assess the projection of the lips and in proportion with the distance between the nose and the chin. Also, we will look at some of the limitations from these non-surgical treatments, which can be, for example, the presence of hypertrophic submental fat that will disrupt that cervical mental angle. Also, we will evaluate the thickness of the skin, which we know that sometimes will influence our product selection and how we use our product. and also the presence of not just hypertrophic submental fat, but jowl fat that can distort the mandibular line, and that will be a limitation for us adding more volume. In terms of the techniques, this is something that we're going to practice with our 2 patients in about 4 or 5 minutes. So the number one thing that we will do is, remember, we're going to increase the length of the mandibular line. And how we do this? By increasing the projection of the chin. And we know that the chin will frame that mandibular line, because by us bringing it forward and down, we're really going to frame that lower face. Then we will also focus on the more lateral part of the lower face, the jawline, and we will focus this differently with our male and female patients. For example, here you can see there we're avoiding adding any volume anywhere around where the jowl is, and we're focusing on treating these different layers that we discussed earlier. For example, in the chin, we can treat deep as well as superficial. In the jawline, most of our treatment in the jawline along the inferior border is focused superficially, as we want to inject away from these vascular risks. And in the gonial angle itself, especially for our male patients, we can afford to increase it, so we can multi-layer, and that means we can do a deep injection as well as superficial fanning. So our female patients, we want to work on the inferior border, as we will see later on. So remember, this is an image adapted from our book, Lee Walker's book, and that I co-authored with him. And our injection points are away from where these vascular risks are. So in the chin, deep. In the gonial angle, you can inject deep. In the rest area, we will focus our treatments superficially. So the main goals here will be, from an anterior perspective, to increase the bigonial width for our male patients, and for our female patients to give a straight uninterrupted mandibular line with a contoured chin. So that from the profile, we have that 120-degree angle or 30-degree angle on a female, more obtuse than that sharp angle from our male patient. Very briefly, we are going to talk a little bit about products, because we have here 2 different technologies. So we have Ultra Deep and the PureSense technology, which is a traditionally crosslink product. It is a 10% crosslink, so it's a rigid, deep volumizer with a great lift capacity. So that means that this is our super periosteal volumizer. And you can see that, like, in comparison with some of the other deeper volumizers, it has an excellent lift capacity. So that means that you are able to project those tissues by adding deep volume. Now, the RHA technology is completely different. The RHA technology is the first innovation in hyaluronic acid engineering for over a decade. And it's manufactured using the preserved network technology. This means that we try and preserve as much as possible of that dynamic network of hyaluronic acid and those natural bonds in between, making it a very dynamic volumizer. And we assess its performance by considering 2 parameters, which is the malleability, the stretchability of the gel, as well as its dynamic G prime. So how long it's able to sustain that G prime, because we have multiple constraints, multiple movements, and our gel is constantly being compressed and stretched where we place it. So we want to assess for how long can my gel maintain its structural integrity. So that is the strength of the gel. How long can it hold its G prime for? And also with the RHA technology, we have other products, for example, RHA3. RHA3 has the same concentration of hyaluronic acid as RHA4, which is 23 milligrams per mil, but it has slightly different engineering, so less cross-linking, only 3.6% versus the 4% of RHA4. So this is a great volumizer for your older patients or for patients that have thinner skin if you're going to fan it superficially. So we have the option of 2 different technologies, which is the Pure Sense, traditionally cross-link technology. This is our ultra deep or deep superperioral. And the RHA technology with its combination of stretch and strength that will be able to maintain its G prime across a wide range of stresses, and it will be able to adapt to movement. So we're going to be showcasing these two different technologies with our patients now. So just for reference, this is the references that we used for this presentation. And now, before we move on to the live demonstrations, I don't know if we have any questions. So I'm going to stop sharing my screen. And if we can now, I don't know if we have any questions so far before we move on to our first beautiful patient.
Hi, Dr. Raul. So at this point, we still do not have any questions. So I think we can move on to the patient and let the audience kind of warm up a little bit, and then they will start putting their question. Oops, I see one question coming in. So maybe Dr. Raul, for you move to the patient, how do you treat the marionettes, and what technique can you suggest?
Okay, so I'll show you my approach to this with our lovely patient. So let me introduce you to Sophie here, our first patient. And one of the things that we do is for this, remember, we want to create softer contours. So that is something that we want to achieve with our patients. Now, remember, the focus here is male and female differences. However, we can discuss some of these changes. Number one, if we want to create, if we can move into the assessment, please. If we want to create a softer contour, so if we can just go a little bit lower, that's perfect, thank you. And what we want to do is soften the transition between the gel and the chin. Remember, what we want to do is you want to treat layers that have a lot of volume. So we are going to focus on treating the superficial fat, which atrophies, and also restoring the bony projection of the chin, which will also change as we age. So that's how I would approach that. Just think of what layers have lost volume and then restore the volume in those layers. So here, we're going to focus on two different things. So we're going to do an assessment here. Sophie here very kindly came to see us here today. So we're going to move to the next position. So if we can just zoom in a little tiny bit. Excellent. So just put your head back for me. Excellent. Okay, so what have we drawn here? So what we've drawn is, first, you'll notice this red oval here that I've drawn here. What does this correspond to? This corresponds to the gel. The gel is super fat that expands as we age. And you can notice that it can potentially disrupt this mandibular line, which I've drawn in the white. So this is something that we consider. And just medial to the gel, we have the mandibular ligament. So remember, that's our first osteocutaneous ligament that will separate the jawline from the chin. And then just lateral to the jawline, anterior to this masseter muscle, we will have the premasseteric ligament. So those two fixed structures. First, let's focus on the chin itself. So we've drawn here the fibers of the depressor anguli oris. Now, in the depressor anguli oris, remember that this muscle, and then we have the mentalis muscle here more medially, then we will have the depressor labii, and we will have the orbicularis oris muscle as well in very close proximity here along the chin. Why am I highlighting the musculature? It's very mobile, and as we age, we will lose some of the deep bony projection, but also we lose all of the superficial fat along the chin. So from the mandibular ligament all the way along the chin. And what is the result of this? Well, the result is what we call dynamic discords. So you see that only elevator there of the lower face, the mentalis muscle, dimpling the chin, rotating upwards, forming a labiomental crease. You see the DAO muscle pulling the corners of the mouth down. So this is why we take care and we explain really what the musculature is and also the aging process, because we are going to use these different layers to our advantage when we're treating our patients. In the chin, we have, in terms of bony projection, we have 3 areas that we can use to our advantage in order to give the chin projection. So the pagonium, the point of maximum anterior projection of the chin, use forward. Then we have the gnathion here, which will achieve 2 things. It will bring the chin forward, but also it will bring the chin down a tiny bit. And then here on the inferior border of the mandible, we have menton. And menton we use if we only want to elongate the chin without adding any anterior projection. Now, we also have other bony landmarks, but if you remember that the way the chin will age and also the way that this will change is we will lose the deep fat there and we will lose some of the anterior projection of the chin. And the mandible will lose some of its vertical height. However, most importantly, the superficial fat here will atrophy. If we move to the lateral part here, we can see 2 things there. So number 1, we're going to see the posterior border and the inferior border here of the gonial angle. So remember, in our female patients, this is around 130 degrees. It's more obtuse than our male patients. Then we have the masseter muscle with its fibers pointing towards the nose, and it's 3 different layers that is attached to the bone. And then above it, we have the parotid gland. So we have the option here in the gonial angle of doing a deep injection. This deep injection will be an intramuscular injection because the muscle is attached there to the bone. And what can this deep injection do? Well, it could give more definition and bring this gonial angle out. But we have to be careful with this deep injection. Why? Because for our female patients, remember, we do not want to increase the bigonial width. We want the bigonial width, the bizygomatic width, if we can just zoom out a little tiny bit, Marvin. A little bit more. Perfect. So we want the bizygomatic width to be the more dominant one. So we don't want to increase the bigonial width. So this is why when we're doing a beautification treatment for focus on the inferior border of the chin, so that of the jawline, apologies, so that we can lower it and create a straight uninterrupted mandibular line. Now, from a lateral perspective, if I can just ask Sophie to just completely turn away, please. That's good. So we take into consideration that serous meridian plane, which is better observed if we were sitting up. So that would be a straight line from the nasion, here up here in the nose, to the pagonium. And we want the chin to be within 2 millimeters. But we know that because of the dentition, and Sophie, for example, is a class 2, we know that this is why the chin is more posterior than what we would expect. So one way that you can assess your patient and evaluate if you might be able to correct this with dermal filler is by just asking your patient to, with their mouth closed, just slide your teeth forward a little bit, Sophie. And by doing that, you can see that you can create a straight and uninterrupted mandibular line. So a straight line there by just doing this. Now, how will we achieve this? So remember, the chin, we have 5 layers there. So how am I going to maximize the expression of volume? Will it be by doing a deep injection or a superficial injection or a combination of both? Usually it will be a combination of both, remember. Why? Well, because we need to really maximize the efficiency of our product use, and we want to really take the rheology into consideration. So when we are treating the chin deep, we want to use our deep supraperiosteal volumizer. So in this case, it's ultra deep. And when we're injecting superficially, when I want to give the chin contour, I want to give the chin more definition, I will use my dynamic mobile volumizer in layer 2, which is in that subcutaneous plane. And remember, my dynamic volumizer is RHA. So in this case, I would use RHA4 in a patient with normal thickness skin. And if I had a patient with very thin skin, I will be fanning RHA3 here in the superficial plane. So that's the difference really in terms of what I will be doing. Now, also important for us to point out with our patients, the marionette folds really is the cutaneous attachment here of the mandibular ligament, and then it has a bony attachment. So we see the jowl has a superior portion as well as an inferior portion. And these subcutaneous fat pads become hypertrophic as we age, and that disrupts the mandibular line. So this is why when we contour the chin and we bring the chin forward, that frames the lower face. But then the second thing that we do is we soften the transition between the jowl and the chin. And being able to target both the deeper as well as the more superficial planes will maximize our efficiency of product. Because if you think about it, and you have 5 layers, how are you going to maximize the volume that you create up here? By injecting deep down here on the bone or injecting just underneath the skin. So we always have to think about the arrangement of layers and how to maximize the efficiency of our volume use. So I'm going to begin my treatment now, Jackie. So my treatment approach here will be using ultra deep, so my deep supraperiosteal volumizer, and I'm going to do 2 supraperiosteal injections. So one in pagonium to increase the anterior projection, and then another one in nathium to complement that increase of anterior projection, but also to elongate the chin slightly. Do we have any questions before we move on, Jackie?
Not at the moment, Dr. Raul. But Dr. Raul, can you just quickly let us know how young this patient is?
Sophie is 29 years of age.
Very young patient indeed. And the reason I ask is because really today, not only are we focusing on beautifying, which actually applies to younger patients, I also want to highlight the fact that, you know, in Asia, we have even with many patients who are young that have this kind of issues like Sophie has today. And it's really about, you know, and what you're going to do for Sophie today is really going to be able to apply to our Asian patients.
Absolutely. So remember that the mandible will lack some projection, so you can approach it in the same way that I'm doing here. Again, by respecting those natural widths. So the natural width of Sophie's chin, if you just look straight at the camera, her natural chin width will correspond to her intercanthal width, which also coincidentally corresponds to the width of the base of the nose. So we will stay within these lines. Now, when I'm in Asia, my colleagues say, well, my patients have a wider chin because they have a wider intercanthal width and they want a smaller chin. Well, that smaller chin will not suit the rest of your patient's face. So it's important that we stay within these proportions. Now, by saying this, I'm not suggesting that you widen your patient's chin, but focus on the contour. So focus on creating the chin, anterior projection to the chin, because remember that 0 meridian plane between the nasion and the pagonium will be off because of the lack of anterior projection. So really focus on creating anterior projection and focus on giving the chin some natural contour. And this will make the chin look nicely in lovely proportion with the rest of the face without widening it. Also, I will point out, it's not relevant here for Sophie, but it's important that we understand the limitations of these dermal filler treatments. And if you had an older patient with a jowling and we want to camouflage that jowl, remember that it's important that we don't sacrifice the chin by widening it just to try and soften the jowl. So always think of the limitations and think of what you can and cannot achieve and with dermal fillers, and really just have those limitations in mind when you're doing a treatment planning. So if you just turn towards me, perfect. So my first treatment here, are you okay for me to start? For this, I'm going to do a deep injection in the pagonium. So I'll ask Sophie to just relax your mouth. Perfect, because I don't want the muscle to be contracted. Now we're going to do a deep injection along the midline of ultra deep. So I'm touching the periosteum, and you can see I lose the whole length of my needle as I touch the periosteum. So I'm going to do a soft and slow injection. And the volume that I'll need here will be anything between 0.3 to 0.4. So it's a very soft injection. And this is, remember, ultra deep is our deep supraperiosteal volumizer. Remember also that just medial, just lateral to this midline, we would have the, in layer 3, you will have the ascending mental artery that will be around 3 millimeters there from where we have the midline. So with this deep injection, I did 0.3 on pagonium in order to give the chin some anterior projection, but I don't want to overfill these deep compartments. Now I'm going to do another similar injection here on gnathian to complement this, and this will also help me slightly elongate the chin to respect these natural female proportions of the lower third, which is 1/3 to 2/3. So for this, I'm just going to angle, and I'm still with ultra deep. So deep injection here. And you can see I'm just below my injection point. And very slowly, we're going to do another bolus here. And these are the only deep injections that I will do. Remember that adding volume here for our patients will, if we add too much volume, you can just make the chin feel a little bit tight. And we don't want to really overfill these deep compartments because of that. And also because of the fact that we want to make sure that we maximize the efficiency of our product. So this is as much deep injection as I will do. You can already see that the chin begins to go down and be a little bit more contoured. So if you just turn away from me a little bit, Sophie. Perfect. So we begin to see that just by this deep volume. Now, there's another deep injection some people do in the pre-gel sulcus, a deep injection here. That one I tend to do more in male patients as I want to elongate the chin. So just always be careful with the proportions. So remember that we want to really keep our proportions as natural as possible. So for this next treatment, what I will do is I'm going to complement what I've just done. What I mean by this is we're going to stay within the natural width of the chin. So if you just look straight at the camera. So we draw these lines here so that we can stay within the natural width of the chin. And we'll stay just above where my entry points have been. And I'm going to continue to enhance the chin by adding volume now in layer 2. So now I'm moving to the subcutaneous fat. Just turn away a little bit. And we are using our dynamic volumizer. So we're moving and we're using RHA4 now. We'll do 2 entry points, so it will be one on either side. So for this, I will pinch the skin. A little scrunchy coming up. And I'm using a 38 millimeter 25 gauge cannula with my RHA4. And my aim will be to stay within these lines and above the 2 deep entry points that I did. Why am I starting with the chin, I must say, if I'm treating the whole lower third? Well, because look at how superficial I can be. And also, by increasing the projection of the chin, I'm able to elongate the mandibular line and frame that lower third. So I can fan my product, and if I was treating, for example, the inferior border of the chin itself, you can also lower that chin line by doing this. So for example, if I had a jowl here, I could do a lower entry point so that I can lower this chin line. So this is my dynamic volumizer. So this is RHA4, and I've used 0.2 here. And you can see that the volume I used was exclusively here, just in the midline. So just above these 2 entry points that I created earlier. If I wanted to soften this marionette line, what I would do is do a different point, slightly more superior. So I'll show you exactly how. And with this entry point, I will have access to this superior portion of the marionette. And after I've managed to bring my chin forward, I won't really need that much volume there in that lateral oral commissure or that superior portion of the marionette. You can see again how superficial I am. And this is just going to soften really the transition between that superior part of the jowl and support the lateral oral commissure. So this is RHA4, my dynamic and really stretchable and strong volumizer. So now we're going to move on to the posterior part of the lower face, so to the jawline. And our focus here will be to focus on the mandibular line so that we can give it a more anterior projection. And the way to do this, so there's several ways that we can achieve this. For example, you can do an entry point here at the gonial angle and then fan your product. The only issue with that is then the hair and the neck gets in the way. So what I like to do is I will do an entry point going from medial to lateral, but we're targeting here our layer 2. So we're staying very, very superficial for this treatment. So we measure the length of my cannula, and that will help me decide where my entry point will be. And I will proceed to do that part of the jawline now. So why am I staying for the inferior border? Well, because remember, I don't want to increase the bigonial width. So I really want to stay on the inferior border. And you can see that I'm staying very superficial. Same strategy, we're using our dynamic volumizer, RHA4. And the aim of this, look at how superficial you can be. This is how superficial you can be with RHA4. And when I tent my cannula, I can simulate that nice contour that I want and definition that I want to create with my product. So very, very slowly, and remember, you have to be very generous here with the volume that you use, but I'm very, very slowly going to start retrograding my product towards my entry point. And I'm not fanning it along the lateral border because I don't want to, again, increase that bigonial width. But the beautiful stretch that RHA4 has means that I can leave the product, and then with one press, you can see that it's completely smooth. And this is because of the nice stretch that the product has. And I've not made her bigonial width increase. So I've focused there on the inferior border. Now we're going to do exactly the same for the chin line. So remember, we're just improving all of the mandibular line. We've already brought that chin forward and down. We've softened that marionette. So now we're going to continue to define this mandibular line. So we're going to focus with the inferior border of the chin. And this will be my last injection here for this side. So again, inferior border, because with this other entry point, I was targeting the chin anteriorly. So now inferior border, same depth. So we're going to be layer 2. So you can see that most of my volume here has been along layer 2. Going to find our little entry point, and same approach, which is we want to create that straight line here. So that straight line will help me just lower that mandibular line and create that illusion of a straight line here. And also, we are able to massage this and mold this very easily. So really, without using very significant amounts of volume, we can create the projection. So if we move back to the assessment position, please. I'm just going to ask you to put your head up a little bit. Perfect. So what can we see here? Well, we can see, number one, from a lateral perspective, you can see that projection of the chin has been moved forward, and I'll share with you on social media if you want the 3D images so that we can quantify how much this was projected. So we projected the chin forward. We lowered the mandibular line in order to create the illusion of a straight and uninterrupted mandibular line. And we've not done any superficial placement on the left side. And what you can see is, yes, we've achieved some improvement by bringing the chin forward, but you still have that superior portion of the jowl. And we don't have a mandibular line that is as well defined, or it's straight and uninterrupted, as we do in the treated side, minus the redness that we see. And this was achieved by using 0.3 deep of ultra deep on the periosteum on pagonium, 0.2 of ultra deep on the gnathian, and then we've used a combination of around 0.3 of our RHA4 to 0.4 here superficially along the chin, and then another 0.4 along the posterior border and the inferior border of the mandibular line in order to create this anterior projection. And now you can see that that E. Ricketts line, so if we go from the nose to the chin, it's in more harmony, because we see that upper lip, it's around 3.5 millimeters from that line, and that lower lip around 2 millimeters from that line when we take it into consideration. So we see more harmony here in the lower third without really widening the chin or widening that bigonial width here. So that's multi-layering, respecting really our patient's female features, and using both the deeper planes as well as the more superficial planes to our advantage by using two different technologies, using a traditionally cross-linked product ultra deep on the periosteum, and then using our dynamic volumizer along the subcutaneous plane. And you saw there how easy it was to mold the product itself.
Hi, Dr. Raul. Yes, we can see very clearly on our screen. And I think many doctors are glued to their screen at this moment. I'll just make a quick comment. I have some comments about doctors who are not able to expand their screen because they would like to see your injections in full view. Doctors who are having this difficulty, you can definitely choose the view on your device, either to select full view or the speaker's view if you have, and you will be able to see Dr. Raul's screen in full. So that's the first comment I'll make. Dr. Raul, if you're okay, we can take a few quick questions now.
Of course.
Yeah, just on Sophie, yes. The first question, do you practice aspiration when you are using a needle injecting filler into the chin area?
No, I don't aspirate as you saw me just a few minutes ago. And the reason for this is because you have to look at the evidence for what we're doing. So you've just seen a targeted approach, targeting the different layers of the face using the rheology in advantage in marriage with the biology. So we have to really become more deep thinkers and think of why we do things. Are we doing this because you were told to do it? A couple of things. If you look at all of the literature that is supporting aspiration, there you will find that there's no quality evidence. Why? Because there's too many factors that will influence a positive aspirate. That is how rigid the volumizer you're using, how long you aspirate for. So we know that for the deeper volumizers, you have to aspirate around 0.4. So that means you have to empty half of the syringe and aspirate for around 30 seconds also, while remaining perfectly still. I've never seen anyone do an aspiration correctly. And also remember, the gauge of your needle and whether it's primed or not will also influence this. So that means that if you were to prime your needles with saline and aspirate for as long as you have to, that means that you might have a more reliable test. So it's a very unreliable test, and because there are various factors that will influence it. Now, the other thing, which to me, as a scientist, is the most important one, is a gel is a non-Newtonian fluid. It's not a liquid. So when you're injecting a liquid in someone like lidocaine or whatever it is, it makes sense to aspirate. Why? Well, because you're injecting a liquid. A gel is not a liquid, therefore it will not behave in the same way. So just look at the evidence and look at how many factors will influence the fact that you'll get a positive aspirate or not. So just think about what you're doing. Now, what can you do? You can do things like you can, remember, do a slow injection. Why was I doing slow injections, and why was I saying that I was doing a slow injections? A slow injection is under low pressure. Pressure is the enemy if you are concerned with vascular occlusions. So this is why injecting small amounts under low pressure is incredibly important. The other thing, keep an eye on your patient, open up a dialogue, and also see if your patient is in any discomfort. Keep an eye on the color of the skin, not just where you're injecting, but all the way all around that area for any discoloration or any signs that you might be in a blood vessel. So just really, I feel that there are other factors that you can concentrate on. And if you look at the evidence for aspiration, it is incredibly unreliable. And if you look at some of the larger international consensus, it recommends against aspirating. So I would just recommend that you think of why you're doing it and just look at the evidence out there and decide if it's something that you want to do in your practice or not.
Thank you, Dr. Raul, for that very scientific answer. So I will summarize: low pressure, small amounts, slow injection is probably going to be safer for you doctors out there if you are considering safety. The next question, Dr. Raul, is on product selection. So can RHA4 be injected deep into the chin area? Would that give you the results that you are looking for?
That's a great question because RHA4 is a very strong product, but it has stretch. That's why I was using it superficially. So yes, you can inject it deep. and it gives you a great overlying projection. But because it has stretch, remember, it behaves more like it tends to spread a little tiny bit more when you target those deep compartments. So you won't feel it like a bump in those deep planes where you inject it, because it has a little bit of stretch. So that means that it will give you that overlying projection, but it will just spread a little tiny bit. It will stay like a rigid little bump where you place it.
Yeah. Okay. Thank you, Dr. Raul. And for treatment of the marionettes, so Dr. Vivian here has asked, have you ever encountered any patients who complain of the worsening of the marionette lines after filler injection in that area? Her personal experience is she met a Caucasian patient in her late 30s who had filler at the marionette area and noticed that it made her look worse. Can you give us a plausible reason as to why this happened?
Yeah, of course. Incredibly simple. Remember, the jowl and the marionette will be lateral to the ligament. So when your patient is lying down, it's very important that you draw and that you establish where the jowl is, because when your patient is lying down, it's difficult for you to know exactly where the tip of your cannula is. So if you inadvertently place more volume lateral to that ligament, you will make the jowl heavier, same as if you go through it in order to enhance the jawline. And that will make it look worse. So you just have to be careful where you're adding your volume. So I suggest that you do your markings with your patients sitting up, and you pay very careful consideration to where the tip of your cannula is.
And Dr. Raul, just now in your injection, we realized we can notice that you really injected RHA4 very superficially, whether it was in the marionettes or the jawline. Can you give us some assurance it will not be lumpy or bumpy? Because I can imagine a lot of doctors looking at it and say, oh no, is that going to be lumpy after? Can you share your experience?
Well, I mean, you've just seen in Sophie that I placed a significant volume, especially for that inferior border of the marionette, and I left it bumpy on purpose. So just to show you how easy it is to mold it, so I just pressed it down once and it's completely smooth. But remember, it is an implant. So that means that if your patient has it, afterwards, they will be able to feel where it is. But because of that nice stretch that RHA has, from day one, it will be able to just adapt to movement. It will just be able to stretch and accompany facial movement. Whereas if it was a rigid structure, it will give you good 3D correction, but as soon as you add movement, it will look like a deformation on animation.
Right. Okay. So again, depending on patient assessment. So Dr. Raul, would there be any type of patients that, just on the question about RHA4 being injected deep, are there a particular type of patients that you would just use RHA4 deep and not ultra deep?
Yeah, of course. So if you have a slightly older patient with thinner overlying tissues, then you can use RHA4 in the deeper plane, and that way you will have a softer contour. And then you can fan RHA3 superficially. So you can use the same multi-layering technique, just adapting the rheology to your patient. So using RHA4 in the deeper planes and using RHA3 in that subcutaneous plane. And that will help you achieve the same outcome, but it won't be bumpy, and it will really adapt very nicely to your patient's tissue and anatomy.
Okay, Dr. Raul, thank you. That's all the questions we have for now. So doctors who are online, keep your questions coming in while we now move to the male patient. So Dr. Raul is going to showcase a male patient for us and see what kind of differences, that the male patient is looking for, and how do you achieve it using the same product choice, 2 different products, and using the same multi-layering technique to achieve a different look.
Absolutely. And I'm going to introduce you now to Keith. And one of the reasons why we're really just taking a little bit more time with Keith is because we want to focus on the differences in gender, but also I think we're going to hopefully achieve a very lovely correction here with Keith. So Keith, if you don't mind me asking how old you are? 45 years old, Keith. And he's had lower face treatments, in particular for his chin, about a year ago. And his main concern was really from a profile perspective. So Marvin, if we can just move into the full face, please. So I'll show you what I mean by that. So for Keith, if we look first from an anterior perspective, we look at the bigonial width is actually greater than the bizygomatic width. So again, this is a male feature. So you have a straight line there from the bizygomatic distance to the bigonial width. And this is in part because of the masseter muscle. So if you just clench your teeth for me, I can feel a very, very strong masseter muscle, which is good here for our male patients. You can relax now. Now, as we start to move towards the chin, we see that we have a chin width that corresponds to a male patient, which corresponding again to the width of the mouth. But we see a couple of things that from an anterior perspective, which I will highlight. Number one, we see a little bit of jowling here from both sides, disrupting that mandibular line. And then we also see that cervical mental angle, so the submental fat, also disrupting slightly the jawline. Now, from a lateral perspective, this is where we can see the full picture. So if you just turn completely away from me, that's good, all the way, a little bit more. And head up. No, so just sit up a little bit. There we go, there we go. So what we can see there, so in line with the nasion to the pagonium, we see that we have a class 2 chin. And this highlights or aggravates really that disruption of that mandibular line because of the submental fat and the marionette. So if we ask Keith to just slightly slide your teeth forward, you can see that by just bringing the teeth forward, even just a little bit more actually, Keith, you can soften the marionette and create the illusion of a straight mandibular line. So improving your patient's profile just by doing that. So this is what we want to achieve here with our dermal filler treatment. So just bringing that chin forward, it's going to frame that lower face and it's going to give us that illusion of a straight and uninterrupted mandibular line. So this is what we are aiming to do here with Keith. Now, how are we going to achieve that? So if we just look straight ahead now, Keith, and just put your head back for us, relax. We're just going to do some drawings here. So the first thing here that we're going to draw, so we can just move to the next position, please, will be the jowl itself. So from the mandibular ligament here, we see the jowl fat here that will disrupt that mandibular line. And it's, again, in between these two fixed structures, which is the mandibular ligament and the premasseteric ligament. Here more laterally. And we see that jowl extending inferiorly as it's in between these two fixed structures with both its superior and inferior portions. So this is the area that I don't want to add any volume to because that's where we have that excess of volume there. Just turn away. Now, the male gonial angle is a little bit sharper than our female one. So if you want to feel it for your patients, you press down so you can feel where the inferior border is of the mandible. And then we'll press on the inferior border here. So we've done the posterior border. Now we're doing the inferior border. And you can see that we have more acute angle. So we have around 100-degree angle here. So if we continue on the mandibular line, you can see that as soon as we get to the jowl, this goes down and it disrupts the mandibular line. But when we get to the chin, we also see that the mandibular line is disrupted by the jowl and also the marionette. So we want to create that illusion of a straight mandibular line for our patients by not adding any volume into the actual structure itself. So for our male patients, so we have a combination of things. So if what you want to do is you want to bring this gonial angle out, we can do it multi-layering. So you can do a deep injection here on the gonial angle. And remember, different arrangement of layers here. So we have muscle attached to the bone. So turn away. So we have muscle attached to bone. So if you do a deep injection here, it's an intramuscular injection. But we have 6 layers there. That means you're going to have to use a lot of volume in order to bring that angle out. So if we want to bring this, increase that bigonial width of your patient, what I would suggest is instead of targeting that deep plane, will be maximize the efficiency of your volume by increasing the bigonial width and just fanning your product superficially through RHA4, just like you've seen me do earlier. But here, we're not just focusing on the inferior border, we're focusing on all of the lateral border here so that we can increase the bigonial width. And in a similar fashion, we can also lower the chin line by fanning my product here inferiorly, and then going towards the marionette so that we can soften that transition between the jowl. Here, the difference is that we can afford to widen the chin because it will, if you just turn, yeah, perfect, just completely straight. So we can afford to widen the chin here of Keith because it will respect his features. So we can do a deep bolus here in the pre-jowl sulcus, and this will widen it and also will soften the transition between the jowl and the chin. But also we have to respect that chin width. So for example, our deep injections will be not just a deep injection there in a single one in the midline. So we're going to split our boluses here into two deep injections. But we're going to do a third one here on the pre-jowl sulcus. But then we will focus on the superficial plane to help us really bring that chin forward and to camouflage that jowl. Now, whether you want to do this from medial to lateral or lateral to medial, that is entirely up to you. But we really maximize the efficiency of our volume. And the way to do this is by using 2 different types of volumizers and also by using the deeper planes as well as the more superficial planes here for our patients. So what I'm going to start with is we're going to just remove some of these markings that I've done here. And to do this, I'm going to use this RHA micellar solution. And this has RHA, as it says there, but it also has chlorhexidine. It has dermal restriction complex as well. And it's going to help me remove these markings without making the skin red or irritated. So I'll be able to do that before I start my treatment. And then we will proceed to also disinfect the skin even further with an antiseptic. So this is good for when you're removing makeup from your patients, which we're not doing here with Keith. But when you give them something to remove makeup and you don't really want them to have dryness when you do your treatment, before you do your treatment or after. So we remove here the marks. And also, one other thing that I always ask my patients is just to come clean shaven for a treatment. So I missed that one there with Keith, but that's another thing that I would suggest that you guys do for your patients. So we begin by treating the deep compartments first. Okay, so we are going to treat our deep supraperiosteal compartments first. But we're going to treat them at multiple planes. And we're starting again with the chin. Why do we start with the chin? Well, because when you have a patient that's a class 2, remember the chin will frame that mandibular line, and by bringing it forward, you will be able to create the illusion of a straight, uninterrupted mandibular line. So that's why we begin with the chin, and then we move to the lateral part, to the jawline. We're going to start with our volumizer, our deep volumizer, ultra deep, but we're going to use it slightly different than what we did with Sophie, because we are just trying to respect Keith's natural male features. So if you just turn towards me, Keith. So instead of doing one deep injection, we're going to do 2 deep boluses here in order to help us bring that chin forward. You okay for me to start? Mm-hmm. Yeah. You just relax your mouth. Perfect. So we're starting with our ultra deep, and we're doing a deep injection. So we are going to do 0.3 here. And then we'll complement that with another bolus just lateral to it. But remember, depth here, slow injection. Are we doing good? Mm-hmm. And this is on the pogonium. So not quite in the midline, but a little bit more lateral. And from my view here, I can already see there that projection there of the chin. So remember, this is a very cohesive product. So if you think of lift capacity, think ultra deep. So now I'm just going to complement that with another bolus just lateral to it. And again, this is deep supraperiosteal. And it's just complementing Keith's natural chin shape. And it's going to be a very similar amount of 0.3. We don't really need to elongate the chin, so we're not going to focus on doing any boluses on the inferior border of the chin on the menton, but we are going to do one bolus just underneath the mentalis muscle on the Nathian, so that we can just increase the length of the chin ever so slightly. But then we're going to complement this with our superficial placement of product. So everywhere where I do a deep injection, I will complement that with a superficial injection with my RHA4. So this means that I'm treating the 2 layers that have lost volume. So if I stay within those natural proportions of our male patients, and if I stay deep and then superficial and adjust my rheology, I am able to really significantly maximize the efficiency of my volume use, which means that I will really need less volume to achieve more. And this is something I noticed when I started using this multi-layering technique. The thing that really switched me from the previous brand that I was using was the lower face, and having a volumizer that I could use not just in the deeper planes, because remember, if you're just burying, just turn away slightly, if you're just burying the product, then you're going to have to use more product, because we have this 5 layers here in the chin, and just targeting that deeper plane, number one, won't address the changes that occur with the aging process. And number 2, you will need more because you have 5 layers there to push up. So now I'm going to do another injection here on the pre-gel sulcus. So this is on the lateral border of the mandible, just anterior to the mandibular ligament. And this is another deep one. And this is one that, remember, you're very, very careful with your female patients because you don't want to widen the chin. But in Keith's case, we're going to be able to just soften the transition between the jowl and the chin, and then complement that with our superficial placement of volume. And just remember, everywhere that you inject deep and you're going to lose the whole depth of your needle, you're probably going to need a lot of product to create any superficial volume there. So just be mindful of that when you do your treatment. So always think, how many layers do I have there? And how can I maximize the efficiency of my volume use? So just turn towards me a little bit, thanks. So just gonna do the pre-gel sulcus here on this side. And again, another lateral injection. Deep supraperiosteal. And this is going to be 0.2 again. So we've used this time the whole syringe of ultra deep, 1.2 cc's. Remember, our volumizers come in 1.2, and we've used the 1.2 in the chin. We did 0.3 and 0.3 on pagonium in 2 points. Then we did 0.2 just on the napkin in between, and another 0.2 and 0.2 in the pre-gel sulcus. So we've made use of our deep volumizer here. Now we're going to move over to superficial placement of product. And for this, I'm going to use my 38 millimeter 25 gauge cannula. And I'm going to do two things. Number one, we're going to treat the superficial fat here that atrophies as we age. That will help us bring that chin down and forward. And then we're going to soften the marionette, and we're going to lower the chin line. And after we've done that, then we're going to move to the jawline, and we're going to employ a similar strategy. So here, because the chin width is, the male chin is wider, as we know, we are going to do a slightly more lateral entry point. So my entry point is going to be very close to the mandibular ligament. And I know that with my cannulus, I'm just going to do a little sharp scratch here. I'll be able to reach all of those planes by using that entry point. And if you're anytime if you're in any doubt or where to do your entry point, just use your cannula without touching your patient's skin to see if you can reach those desired by your entry point. So we're going to find this, and you can see how superficial I am there. And this is how superficial you can be with RHA4. So this is what you want to do with this product. You want to place it in this subcutaneous plane, taking advantage of its strength, but also its stretch. And I'm injecting just above those entry points that I did earlier, so that I'm really treating this area. Now we go close to the marionette, but sometimes we need to do another entry point in order to fix that. So if you just sit up for us a little tiny bit there, so we can see what we're doing so far. So Marwan, if we just move down a little tiny bit, there we go. So from an anterior perspective, we can see the chin width has been respected. But if we start to look from a profile, okay, just stop checking yourself out, Keith. Just, so we can see that chin has moved forward quite significantly. If you just zoom in a little bit more there, zoom out, sorry, apologies, zoom out. And we look at the nasion, so you can see that chin is more forward, and we're going to continue to bring that chin forward. If you just turn towards me. This side, I have not treated superficially. So you can see this marionette fold versus the one that we have treated. So this is really the advantage of being able to multi-layer product. And this is why I switched to using this product range. You can relax now. because of just being able really to multi-layer the product has been significantly efficient for myself. So now we're going to do another entry point on the opposite side. So if you just turn towards me a little tiny bit. Okay, so we're going to do an entry point that's going to be similar to the one that we employed earlier. And if there's any bleeding along my entry point, I will just go ahead and put some pressure. And this is where we have to be patient and put some pressure and then do a different entry point. So we've treated layer 5 supraperiosteal, and now we're treating layer 2 subcutaneous. And this is the multi-layering technique. And one thing that we usually don't do is we're not patient enough when there's bleeding. So Jackie, I understand that I just have a couple of minutes left. So what I'm going to do, and we can have a little chat and Q&A, but what I want to do, instead of treating the left side, I'm going to show you the jawline treatment. So if you just turn away from me, not that much, mate. There we go. And here we're gonna use superficially, and I'm using RHA4. This is a 7-centimeter cannula that is 22 gauge, but I'm gonna treat the whole of the jawline via this entry point. So to do this, I'm going to just slightly bend my cannula. So I'm just going to slightly flex it. So do this with good quality metal. And we'll do my entry point here along the gonial angle so that I can target this subcutaneous plane. So for this, we're going to do my entry point right here at my gonial angle. Superficial, sharp scratch there. There we go. And now with my cannula that I've flexed, we'll see if I can find my entry point. And this is different to what we did earlier with Sophie. Why? Well, because we are going to be increasing the bigonial width. So we're going to be this superficial, but we're going to fan the product all the way laterally here so that we can increase our patient's bigonial width. So we established that during our assessment. So it's very important that we stay superficial. So what I like to do is just go closer to my entry point and just take my time to ensure that I'm as superficial as possible. And I can see the outline of my cannula because I don't want to go deep and I don't want to go to the parotid fascia. And after doing this, we're going to focus on the chin line. So for the chin line, I'm going to slightly lower this chin line. So for doing this, I'm going to use another entry point. Because remember, we've already used this entry point here for projecting the chin forward. But now I want to focus on the inferior border. And for this, again, similar to what we did with Sophie, but now we're going to focus here on the inferior border. And same RHA4. This is the same cannula that we used earlier. But here we've injected anteriorly, and now we're injecting inferiorly in order to lower this chin line. As you can see superficially, and with my cannula, I can tent the tissue. So you just turn away and just simulate what I wanted to create. I want to draw a straight line from the tip of my cannula towards my entry point. So very, very slowly and with a generous amount of volume. And then you can see with your RHA4 how easy it is to mold the product. You can see it's a small little bump there, and you just press it once and it's completely smooth. So this is really taking advantage of this dynamic rheology. So if you just put your head up a little bit and let's zoom out a tiny bit. We can see and appreciate a couple of things. From a lateral perspective here, we can see the projection there of the chin, but also the softening of the marionette and the lengthening of this mandibular line. So this, you have to evaluate with your patient sitting up because stretching the platysmal bands does not help. But you can see how we have a straight mandibular line. And also we have a soft transition between the jowl, where the marionette are, and the position of the chin. It's completely different to where we started. And this is the untreated side. So we have not treated this side superficially. So you see here a step there between the jowl and the chin. So from the top down here, I can see a massive step here. But also you see that you don't have that definition and you don't have that projection because we've not placed any product here superficially, nor have we added any volume on the jawline. All right, so Jackie, I've just summarized my treatment. I'm going to proceed to treat the other side, but I think now we can answer some questions because I started off 5 minutes late. So I'm finishing 5 minutes late. So hopefully we're still within time.
Hi, Dr. Raul. No worries. We're not dropping any audience, which means that, you know, everyone's glued to their, in front of their screen. And can I just congratulate you on this beautiful result? Because on Marvin, we can see with this half-face comparison that he's got a really nice contour now, as well as a more defined jawline. And if I may add, just because I met Marvin before the injection, that you've taken as Keith, I'm sorry. Marvin is of course, Marvin is the photographer. Yes.
Marvin will not let me near him with a syringe. So no.
I'm so sorry. And I'm sure Marvin does not need anything. No. But what we are seeing as well is also a bit of this mental, his submental fat, if I may say. Yes. It's not as obvious compared to the other side that you have not injected. So very obvious results from where I am, even though I'm very far away from you, but I can see it very clearly on the screen. So congratulations. So Dr. Raul, actually, we have taken a lot of the questions, and because you've injected very step-by-step with clear explanation for the second patient as well for the first, we don't have any questions for the second patient. But what I'll get you to do is, can you just summarize for us what you did differently for the female patient versus the male patient?
Of course. Yeah. So female chin, we stayed within the natural proportions of the intercanthal width with the aim of bringing the chin forward. Because remember, your patients are going to have that zero meridian plane because of the nasion, the position of the nasion, it will be further back. So we can't really use that as a reference point. So you want to use the E. Ricketts line for your patients and bring the chin forward, staying within those natural lines. And that will help you not just achieve that anterior projection, but also create some lovely contour. Then after that, when we're treating the mandibular line, we stay within the inferior border so that we don't increase the bigonial width, because remember, your patients might even need treatment to decrease the bigonial width by reducing the bulk of the muscle before you move on to dermal fillers. So very important that we aim to preserve that nice oval facial shape. And sometimes it will mean having to slightly decrease the bigonial width before you start. So those are the two considerations that you want to keep really for your female patients, staying within that natural width of the chin and not increasing the bigonial width so that you treat not just the anterior view, but the profile. And for our male patients, remember, we want to have a wider chin. So we want chin width corresponding to the width of the mouth. And also we can afford to increase the bigonial width, so by fanning products to Keith earlier.
Thank you, Dr. Raul. And Dr. Raul, the difference between the male and female you have pointed out, I'm going to take you one notch up. Asian and Caucasian. I mean, you've just been in Singapore last week and you've met a lot of Asian patients, lots of questions on the lower face. Would you do something differently, or would you assess differently if today we had the luxury of having Asian patients in your injection chair?
Of course, and this is why we've been touching on this, not just during the presentation, but also we've done this during the whole conversation. Because one of the things that you'll do, your patients will likely have greater bigonial width, so you want to decrease it before you treat your patient. Also, your intercanthal width might be wider, so your patient's chin might be wider. So what you want to achieve there is anterior projection using the E rickets line instead of the zero meridian plane, and creating contour for the softer contour of the female chin, respecting that natural width of it. So remember, the female chin is not always small and rounded and pointy, so it corresponds to bony landmarks, but you want to create a nice contoured chin and give it anterior projection without increasing the bigonial width. So those will be the things that I would say we should focus on for that particular demographic. And also remember, the chin it's such a high impact treatment, and incredibly popular in Asia as well, because in this younger cohort of patients, it's really an area of beauty, and this is why you probably have more female patients requesting chin enhancement and beautification than what I do here in London. So this is why it's really important to get it right. And there's nothing worse than creating a narrow and long chin in a patient just to try and create an oval, because you're treating an area in isolation that will not be in harmony with the rest of the face.
Thank you, Dr. Raul. And Dr. Raul, from your perspective, what does having a chin or a beautiful jawline really mean to a patient? I mean, like, if I'm a patient coming, there's so many areas I'm focused. I want more beautiful lips. I want nice, chin, cheeks, and then temple. Exactly. I know, but just for the sake of our discussion. But Dr. Raul, what does a nice chin give to a face, or how does it value add to a face that doctors should really look at this area and start treating it if they haven't, and start treating it well if they have?
Well, number one, it will frame the lower face, so it will frame the jawline, and also the facial shape in the oval. So it's really a very key point, especially when you have your patients that have a greater bitemporal and bigonial widths. Is really the chin that's going to help differentiate there between genders and achieve that nice facial shape, that oval female facial shape that is the same across various ethnicities.
And Dr. Raul, it's interesting you will use the word frame, because what comes to my mind is you have a beautiful picture, which is a beautiful face, nice eyes, nose, lips, and that chin sort of give that frame to that picture. I mean, that's the image that comes to my mind, and which is why I think even in TEOXANE we are really going into the lower face beautification, and nicely that you have launched the campaign for us in APAC for the lower face, because we realize how important it is to a face to have a strong and a beautiful lower face as well, and more so for the Asian population. So before I let you go, Dr. Raul, we have actually two questions here. Just now on the patient's left, a small little vessel was, there was a bit of there was some blood coming out. What do you think happened there? Was there a specific structure that was being punctured, or what happened, do you think?
Yes, of course. So it was most likely the mental branch of the facial artery, as we saw during the presentation, that gives off that mental branch that then turns into the inferior labial artery. So whenever you do an entry point, if there's bleeding, be patient, put some pressure on it, and then find a different entry point.
Right. And of course, that is also why we stress so much on knowing anatomy. So when you see that happens, you know to not inject and then find another injection point. And then also the last comment, Dr. Rao, thank you for the great presentation. Could you let us know how much RHA4 was injected for the jawline? And would you use any ultra deep for the gonial angle? And this is for the second patient.
If you're gonna lose the whole depth of your needle by touching the gonial angle, then you're gonna get very little efficiency of use there. So it depends really what you're trying to achieve. I find that using the superficial plane will help you very nicely contour and create those sharp angles. I used in the jawline, we only use 0.3 actually superficially in the jawline, and this is because Keith has, remember when we look at he had quite a significant bigonial width, so we just wanted a little bit of definition. I was not trying to increase the bigonial width in him because he already had a greater bigonial width. So for example, if I was having a treatment, I would want to increase my bigonial width. But with Keith, I didn't want to do that. And in the chin, deep on the pagonium, gnathian, pregel sulcus, we used a total of 1.2 deep of ultra deep. And we've used so far 1.2 superficially in the chin of RHA4.
Thank you, Dr. Rao, for that summary. So a very efficient use of products when you use the right technique addressing the different layers. And I think that is one of the key things you want to leave our doctors with. So Dr. Rao, very quickly, summarize what is important for the lower face for our doctors to consider.
ATP.
Okay.
Anatomy and assessment of your patient, taking into consideration gender and ethnicity. Then based on that and your patient's need, you're going to choose your technique, what works best in your hands, and then we're going to marry the rheology with that. So we're going to take into consideration what layer we're treating, what are the characteristics of these tissues, and we're going to use the right applied rheology for these different layers in order to maximize our outcomes.
Thank you, Dr. Rao. Lots of thought-provoking points that we take today. And I'm sure our audience this evening really benefited. Thank you, Dr. Rao, all the way from London, setting up this beautiful setup in his clinic so that all of us can really see how the multi-layering technique is being utilized in the lower face. So thank you, doctors who are online this evening. Thank you for spending your evening with us. I know it's pretty late in some countries. Australia especially. Thank you for all of you who stayed with us. And thank you, Dr. Rao, for spending your time with us. And I'm going to let you go. Just before I let everybody go, I'm just going to do a little bit of marketing. In 2 weeks' time, we are going to have another webinar. This time, still focusing on the lower face, we are going to have Dr. Lee Walker from UK, as well as Dr. Wilson Ho from Hong Kong. Many of us know Dr. Lee and Dr. Wilson Ho very well, and they are going to talk specifically about the lower face and considering the anatomical risk. So you're going to hear a lot about the anatomy as well as how to avoid the major structures. And yes, Dr. Rao is holding up a book that he co-authored with Dr. Lee Walker, and that is going to be, I bet, the basis of a lot of our discussion in 2 weeks' time. So you will get the invitation very soon, doctors, and we're going to leave this slide on for just a minute. So if you have your handphones with you in your hand, you can take out your handphone and scan the QR code and register for the webinar immediately. If not, then you will definitely get an invitation from your sales representative in your respective countries. So with that, I want to thank everyone for your time and see you soon in 2 weeks' time. Thank you, Dr. Rao. Bye from Singapore.
Thank you, my friends. Lots of love. Stay safe, everyone.
Stay safe. Bye.